Okay. All right. So good morning. Assalamualaikum. I would like to do a presentation, a short elective posting in emergency department in Palmerston North Hospital, New Zealand. For the past, I mean, not for the past, for the previous 1 week in New Zealand. So it's the overview of my presentation would be, I will roughly tell about the outline, which is the overview and some of the objectives and the preparation that I have done, and more on the Department of Emergency in Palmerston North Hospital, and a bit of other pictures as well. So the others can just join once they join the presentations. So a bit on the population, comparatively, Malaysian in year 2024 is a total of 35.5 million population compared to New Zealand. We have almost about the same size of land, but New Zealand is just 5.3 million population as per year 2024. Wellington alone has 175,000 population by year 2025. And from the map, sorry, not Wellington, Palmerston North. So Palmerston North is located at the North Island. North Island, and it's on the southern part of the North Island. So it's a very small town, beautiful town, beautiful weather. All right. So the observership was just for a week, 6 until 12th of October. And the objectives were simple, that I wanted to observe how the department runs and exchange information and compare with how the Malaysian system work in terms of triaging patient, treatment, investigation, even certain medication that was used that I'm going to share later, and basically learn. I would say the elective posting, when you do it outside of Malaysia, is basically an eye-opener of how things work differently in different hospital. Yeah. So, and you see how the culture, the working environment, and I will explain later. So the preparation, this is for my other colleagues. The preparation is almost about the same as others that went through overseas. You got to inform your supervisor, Prof. Khaldun, because Prof. Khaldun is our lecturer, emergency physician in HUKM. Apparently, he has many contacts overseas, colleagues that you can get help from. Otherwise, other than that, you have to apply your leave form. You need to inform the bahagian pengurusan latihan that you're going overseas for elective. And then in my case, I contacted Dr. Nasrina. Dr. Nasrina is a consultant emergency physician in Palmerston North Hospital, New Zealand. And we had to fill up few forms, and we have to submit certain form, CV, APC, MBBS, and also declaration of confidentiality, health declaration, and criminal conduct, and other information. Basically, Dr. Nina helped me a lot in getting the observership posting in New Zealand. And other preparation is your visa, your rental, your Airbnb. Make sure your passports is available, and WISE is always acceptable anywhere in other countries as well, and also the eSIM. In New Zealand, a bit on New Zealand healthcare system. It is under the Healthcare New Zealand, or or I was told that WH, because that is the native New Zealand language. So WH is pronounced as far. It replaces F. So Tifa Tu Ora means health, New Zealand. This Health New Zealand runs all public hospitals and health services. And it was established in 2022. It replaced the other 20 district health boards in New Zealand. It's divided into 4 regional divisions: Northern, Central, and Te Mawanataki, Southern, and funded through general taxation. And it is public hospital. It's free for eligible residents. They don't have to pay. But GP visits, they have to pay co-pay, usually about 60 New Zealand dollar for adults. This is the consultation rate. And children under 40 is free GP visits. Regarding the Palmerston North Hospital, it was first opened in 1893. It's the primary public hospital. It is operated by the MidCentral District Health Board, which serve Palmerston North and the surrounding district. It's one of the major trauma center alongside 4 other hospitals near it. This is the picture actually taken from just in front of the emergency department. This is the entrance of the emergency department. So the hospital has 350 to 360 beds for most clinical service. It has broad range of service like ED, PITS, medical surgery, cancer, even mental health. So basically, it's in Malaysia. It's like a tertiary hospital. It has OT. I mean, it's not a district hospital. So okay, these are the pictures that I took from my elective posting. On your left, that is the registration and the primary triage counter, where a patient that walks in will register and they will have their own National Health Index number. I want to highlight these NHI numbers. This is something we don't have in Malaysia, where one person carry one number. It's like a health record where any healthcare can access to this record, meaning there's a continuity of care. When the patient comes to the hospital, treatment was given, and let's say he was discharged, the GP would able to access the admission or the treatment info or what was done through the system. So this is something that we don't have in Malaysia. Like like you're carrying your identification card, but it also has a health record. So it's easy for the treating doctor. Let's say a patient was traveling from Wellington to Palmerston North. So it's easy when it's all recorded in one number. And this in front of the counter is the waiting area. Basically, this is where the category 3, 4, 5 will sit until they'll be called to be seen by doctor. So the staff nurse in the blue scrubs is the one that gonna triage the patient once they registered. And primary triage in Palmerston North Hospital, they use Australian triage scale. It's not like us where we use green, yellow, and red zone. So they go by code category 1, 2, 3, and 4. So 1 and 2 is basically life-threatening or potential life-threatening will be treated inside the resuscitation area, where 3, 4, 5 is they have to wait outside the waiting area. So this is very quick assessment form that the triage nurse. By the way, the ED, they don't have a medical assistant or paramedic. They are run by staff nurses, senior staff nurses, and nurse practitioner. So the triage staff nurse would triage based on this, And I would like to also highlight there's a chest pain pathway in the triage itself, where patient who presented with chest pain or any chest pain equivalent, they would have to do an ECG, and this ECG needs to be reviewed by the consultant emergency physician or the registrar, so that patient can, I mean, if it's MI or it's whether patient needs to be resuscitated in the resus area or they can wait in the green zone. Sorry, in the waiting area outside. This is the secondary triage, where if patient were to wait outside, they will be taken into this room for vital signs, ECG, X-rays, blood taking, and the staff nurse can prescribe simple medication like paracetamol and ibuprofen for pain management. And I would like to also highlight they have a triage away where, you know, patient have to wait for too long. And their green zones patient, what I saw the difference was patient willing to wait in green zone. They know their cases is not life-threatening. Because in Malaysia, sometimes you have patient knocking the door asking, why am I not being seen? Even though waiting for 1 hour and they came for fever. So the other thing that they can do is they can write this down for triaging away patient. What was some details and reasoning for declining redirection if they want to stay, if they don't want to stay in ED. So they have this video consultation. It's called Practice Plus, where emergency redirection information, where they can call and they can get consultation over a call, and they will be advised to go to the hospital in case they need to. And they also have urgent care extended hours if they want to seek treatment, non-emergency treatment. Okay, this is the highlight of my presentation. Actually, the central station is like an island surrounded by all the resuscitation area. I was amazed by this idea, maybe the first time I'm seeing it, but everything is at the center and it's surrounded. You are overlooking all the resuscitation area next to you through the glass. And this is the treatment bay, the resuscitation bay include two major trauma bay and also the central monitoring and patient updates. So I'll go a bit detail on this. Okay. Okay, the first picture on your left is the 4 big screen on the central station. This is where all the patients in emergency department is being listed, their location, their diagnosis, their active plan, their length of stay, and whether the patient has been seen by the primary team or not, whether, basically everything is here. You don't have to, because in Malaysia, sometimes looking for patient is already another 15 minutes job for patient and also for file and everything. So this is very organized and centralized. And this big screen is being updated by the staff nurse in charge, uh, which I will show again later. So the next picture, the middle one is the monitoring that is being attached to the critically ill patient, like cardiac monitor, vital signs. It's more like an ICU care setting in Malaysia, where this monitoring can be seen by everybody in the central station. And the far right picture is the bed manager live status, where they know whether the beds is available, not available, medical beds are all full. So they have an idea about the bed status in the hospital. Okay, the first picture on your left is where the staff nurse in charge will stand. This is where she controls whatever happening on the screen on your left. She will update, and she has a big microphone also there for her to ask, maybe Kevin bed 6 status, whether it was referred or anything. So he will just update the screen. And the staff nurse in charge also take calls from the pre-hospital care if there's incoming category 1 or category 2. In our terms is resuscitation case coming in. So she will also mobilize bed if bed is needed. She's an important person. Uh, yeah. Okay. So the image in the center is where the incoming patients, the incoming pre-hospital care patient will be seen, as you know, it will be written as time before arrival. I mean, and also what category, and it's there on the screen. And the right picture, the right far picture is the pre-hospital transfer care, where they have to write down, you know, when they receive the passover from the pre-hospital care team. This is the overview of the central station, where the doctors from the primary team, the staff nurse, everyone will be at. So I think it's very organized, something that we don't have also. The concept of island in the middle. Okay, they have a functioning pneumatic tube. We had it in Malaysia, but it's not functioning. This is the medication bay just behind the island where all the medication is stored. This is the ultrasound. I managed to experience. I mean, we did one ultrasound in one patient, Dr. Amir. If you could remember, we did an echo in one of the patient with dilated cardiomyopathy. Oh, the X-ray was top notch, and it's easy to mobilize. Okay, it's not the big square one that we have in Malaysia. You can't squeeze in between patient. So the left picture is where the resuscitation bay looks like, and the right one, this is the major trauma resuscitation area, where I mean, it has bigger space. It has all the emergency trolleys and all the equipments here. Uh, a bit on the pre-hospital care ambulance service, because the ambulance service is totally separated from the hospital. It's not under emergency, so not much information can be gathered. But it runs independently as a national charity, but it's also under the Ministry of Health through its own regulatory frameworks. It's being run by St. John Ambulance Service. This is something I want to highlight also. In the Palmerston North Hospital, they have a ENT/Opta room where they have a slit lamp, the one that I showed in the picture on your left. So where you can actually, it's like a magnifying glass that you can see through, you know, the cornea, and if you see against the wall, they have pasted the examples of, you know, diseases and how it's looked like. This is something we don't have. And the picture in the middle is to check the intraocular pressure. This is also very easy to use. Thanks to Dr. Nina. I mean, she showed me how to use it, the equipment. I mean, in ED, we can only, not much that we can do other than fundoscopy. You know, you have to dilate the pupil, fundoscopy, and visual field, visual acuity. But this is something different. And the eye irrigation, you know, in Malaysia, we will just use normal saline and put a needle in and just squeeze the water out from the needle for eye irrigation. But this is the proper way of doing eye irrigation, the far right picture. A bit on the pediatric bay. They have a pediatric bay in the emergency department where only pediatric cases are being seen here. And they have quite, I mean, the whiteboard is easy, you know, in case of emergency, that everything is written so that it's easy for you to calculate the dosage of pediatric dosage. This is a subacute area where other places that in the emergency is that they have subacute area with, I think, 10 beds or 8 beds, I'm not sure. And they have ED observation unit. I read about this ED observation unit. It was only recently being installed, I think 2, 3 years ago. Yeah. And the far right is the orthopedic clinic. Okay, in case of a simple fracture that being seen in emergency department, let's say a distal end radius fracture undisplaced, the nurse practitioner can just apply a POP and a checks, and then patient will be given clinic outpatient to see orthopedics the next week. So a simple fracture that can be managed by emergency physician with applying POP and seen by orthopedic the next week. This is also a good idea so that, I mean, you can decongest ED faster. Another thing is about it's all computerized system. Because in Palmerston North, they use MidCentral Direct Health Board where they can access. This is a secure online system that being used by the hospital and health professionals in the central region to access patient information. So this is what I meant by easily access health information with using, I mean, just one NHI number. The guidelines are a bit it's standardized. I mean, they have a Starship for antibiotic guidelines and pediatric guidelines. And on your on the right side picture, I mean, I want to highlight that this is a something that Malaysia should have, where the policy for acute admission and allocation of clinical line, where, if you're not there's a proper guideline that tells you this case should be referred to which team. So in Malaysia, sometimes we have the problems of primary team not accepting, I mean, because they don't think it's their case. So if you have a proper guideline like this, black and white, it's easy for disposition or referral to the primary team. Uh, yeah. And yeah, this is also something that amazed me because the population in Palmerston North Hospital in Palmerston North is elderly. The population of elderly is quite significant, and they are functioning elderly, 80 years old. I was told Palmerston North is a retiring city, retirement city. So New Zealand that wants to retire, they go to Palmerston North. So about a bit on paddle. Paddle is specifically for geriatric. It's in charge by one of the staff nurse in emergency Palmerston North, where the aim is to identify older patient in ED whose admission might be avoided, and they can benefit from a comprehensive multidisciplinary assessment and community-based support. Meaning when they discharge an old patient, let's say an old patient comes in and they will plan, I mean, they plan to discharge the old patient, they have a wrap around blanket management, meaning they would assess patient that is frail, multiple comorbids, who has any fall risk at home. This, if they think needs to refer a social worker or allied health or any district nurses, even they can alert the GP, meaning all this is necessary to as an early intervention in functional decline, fall risk, and social issue that often lead to recurrent admission in elderly patients. So, okay, this is a picture I took in the Passover. That's Dr. Amar in the center and Dr. Nina. So the Passover is not like Malaysia. We do bedside from patient to patient, from one patient to another patient. So the Passover that I see is very concise. They printed out the patient list, current issue, and the working diagnosis and the disposition of the patient. So it's very concise and brief and straight to the point, because Another thing is once the patient is referred to the primary team, basically the primary team will be in charge of the patient unless the patient collapse. I mean, yeah. So yeah, the passover is in this one nice room. So I want to highlight a few points in my presentation that Palmerston North has 150 to 180 patients per day, ED visits. And I want to highlight that they have a NHI number, which is a structured central medical record, accessible by other healthcares. I also want to highlight that the pre-hospital care is totally separated from the emergency department. It's a standalone organization. And there's no medical assistant in emergency department. I mean, paramedics. The nurses are very competent. They are at par. And they are, I mean, there's no, I don't see, I see everybody is talking the same language with each other, and they have the level of respect that I see. And I want to highlight also the geriatric discharge blanket wraparound plan, which is the paddle. This is very good to prevent recurrent admission. You can early intervene the risk of fall, a social problem, and all. And the referral to the primary team, it has a black and white standardized referral. Last but not least, they have a functioning pneumatic tube. So this is the picture that I took. Yeah, this is the first picture is Dr. Nina herself, the emergency consultant. Sorry, Dr. Amir, I didn't manage to get a picture with you that day. Yeah, this is Dr. Hasina and Dr. Shazwan. They are Malaysians. I think was just about a year in Palmerston North. And Shazwan invited me to his house for dinner. Shazwan's wife is also a house officer in the Palmerston North. And thanks to Dr. Nina inviting me for dinner, we had some sharing moment of the hospital and how the healthcare works. And yeah, I got a very good sharing session with Dr. Nina. And a bit of outside hospital. After I finished the observership, I went to the South Island. I'm not sure whether you guys have been there, but New Zealand is just it's just beautiful. The weather, and the first picture was taken in Te Anau, because New Zealand is famous for the dark sky reserve, where there's no light pollution at all in New Zealand in certain places, where this astrology photographer would just go and take picture of the skies. So it was pitch dark, and you have to wait until 10, 11 just to take the picture. And Milford Sound is one of the destinations that tourists would go to see the waterfalls. And I stayed in Queenstown, where outside the house it's just all the snow-capped mountains around you. And I got so many pictures to share, but I don't want to take a lot of your time. So I think this is my final slide. Uh, and I would finish, I mean, end my presentation. Anything from Dr. Nina and Dr. Amir? Before that, I would like to introduce Dr. Nina is the and Dr. Amir is the consultant emergency physician in Palmerston North Hospital, who helped me and showed me around around the hospital. Dr. Amir is the head of department of the uh, emergency department, Palmerston North. And I would like to introduce Prof. Khaldun. Is our hi Prof. Good morning. Assalamualaikum. Yeah, Prof. Khaldun is our consultant emergency physician and lecturer in HUKM. Yes, Prof. You have any?
Okay. First of all, I would like to congratulate Susof for Nurizam for a wonderful presentation, and thank you for the sharing of your experience. I think that's the whole idea of why we are actually encouraging our students to go out from Malaysia and sample what emergency medicine is, how emergency medicine is practiced somewhere else, so that will enrich our students' perspective of how to manage a patient, not just from one side in Malaysia, but you have a better grasp of understanding of how things can be different in a different place and different patients, cohort, and so on. So thank you, Suso, and thank you also to Nasrina and Dr. Amir for accepting our students. I hope it's not going to be the last one. Well, we hope to have more opportunities in the future, and vice versa. So we also open our observership or elective for Malaysia, and in UKM, our hospital, we've been receiving students from all over the world as well. So we should share this opportunity with you guys in Palmerston or in New Zealand. So I have a few questions actually to Susof. Is it okay if I ask, and Dr. Amir and Dr. Nina can also add on for the information? I just want to ask, there are a few questions actually I want to ask. First one is starting from this NIF or NI number, national
Health
the
index.
registration number. Is that
Mhm.
kind of separate from the well, we have the IC, right? ID IC number, or some places have social security number. Is that a completely different number to their registration, or linked up with that as well?
I think I'll answer that question. Well, first, well, good afternoon from New Zealand to everyone.
Good morning.
I really appreciate the opportunity and the invitation to join you as you reflect on your week with us. The presentation was outstanding, and I'm actually impressed by how much of the workflow and the systems that we have in the ED, how much of that you've captured in your presentation, Nurizam. So really good presentation with very insightful bits and pieces to share with the team. I also want to thank you, thank your professors and supervisors for the amount of work and the effort that has been spent to facilitate 1 week here. It's a short period of time, and I'm sure it took a lot of planning and preparation and support. So thanks everyone for making this happen. Nina has been the key ring in the chain that connected Malaysia and or connected your program with our program. In terms of the question, so the NHI is a number. It's a healthcare number, as Nurizam summarized. It's not related to necessarily to a national identity or a security number. It's almost the number of the health passport of the patient, but it's all electronic. And it's something that, as Nurizam said, that it facilitates the continuity of care and it facilitates accessing patient records.
Okay, so what I mean is, it's not just for New Zealanders; it's for everyone that is being treated, and it can be accessed throughout the country. Am I right? And
yes, absolutely. So
yeah,
it's electronically generated, and
okay, and this also not just limited to hospitals, but also accessible to the GP.
yeah. So this number will be allocated to the patient to as almost a code of their healthcare profile, whether it's GP service, whether it's physiotherapy or hospital level of care.
So that's the question that I want to bring up, where you have integrated GP system with the hospital system. So that is something that is not existing in Malaysia. I came from a different system as well. I was in Ireland, and we've integrated. This was way back, being integrated for a long time
Yeah, yeah.
ago, for GP care or continuation of care when the patient is discharged from hospital. So at that time, it wasn't electronic. It was still manual. So we had to write the summary for the GP to take care of the patient when they go home from the hospital. And it always goes to the same GP that the patient is registered with. So I assume it's the same system in New Zealand, where one patient only have one GP that is managing them, unless they want to go for somewhere else. They need to get a referral from the GP for the other GP. Is that correct?
Yeah. Usually I think that's a good summary of it. Just maybe a few minor correction. The patient are required to enroll with a GP. If they don't enroll with a GP, the primary healthcare becomes very expensive,
Oh,
and they
okay.
cannot receive subsidy from the government.
Oh, okay.
So it
All right.
becomes
Is
very
that
expensive
for everyone, or is it for just New Zealanders?
for everyone who's
Oh,
well. I mean, every resident or
hmm.
everyone with a residency status or a
Okay.
special type of visa like work visa,
Okay.
they will need to enroll with a GP. Otherwise, the healthcare becomes very expensive. In terms of the integration between primary healthcare and hospital level of care, there is some integration, but it's far from how we would like it to be. The GPs or the primary healthcare system, they use different software,
Oh,
and
okay.
we use a different electronic system. But they can, I haven't seen it from the
Yes.
GP side,
Hmm.
but from
Okay.
hospital side, usually we cannot directly access GP records.
I understood. Yeah. So it's
So we have hospital records, um,
hmm.
and the GP, but I think the GP they have their own system, but they can when the patient visits the hospital, the GP get notification that their patient needed hospital level of care, and then
Yes.
they can access the records.
Okay.
Uh, and there's been benefits to this. For example, if we see someone with in the ED overnight and an X-ray is done and they've
Yes.
got small pneumonia that was not appreciated in the ED, the
Hmm.
next day the GP may get a notification that the patient visited the ED, they follow up on the X-ray and they found it reported with
Yes.
pneumonia, and then they will call the patient back for antibiotic and a review.
Yeah, so meaning the GP can access all the results and
Yeah,
whatever thing that is being put up in the system, right? So that's very important,
exactly.
because I foresee that this will actually reduce the risk of repeated tests being done, of unnecessary exposure as well, and to pain as well, as what we call comparative. You can have a trend that you can look at, how the things progress at the GP side. So this is not the case in Malaysia. Yeah, everybody will sometimes go shopping for GPs, and the GPs from one place to another have a different set of investigation that they keep, and it's not being passed on to the other level of healthcare. So that's a waste of resources, waste of time and so on. So I think Nasrina and the rest can also foresee that the flaw in our system, especially in the public healthcare system. Yeah. Okay, so that's very interesting. So I want to ask also about the pre-hospital care. You mentioned there's no paramedic in the emergency department. Does that reflect also in the pre-hospital care? Because you said it's a two separate system, right? It's an independent, standalone pre-hospital care. Are they managed also by nurses, or then they have a paramedic for that?
The pre-hospital care is managed by the paramedics.
Okay.
Yeah, they were managed by paramedics.
Yeah. Okay. So meaning that they have their own training system and so on, right? They have their
Yeah.
own level of pre-hospital care service personnel for that. And do they have emergency physician or doctor connected to them or not?
Oh, I'm not pretty sure on
Okay.
that. Yeah.
Yeah.
Yeah, the pre-hospital system in our region, so there are few pre-hospital systems. It's not the same ambulance
Oh,
provider
okay.
throughout the country. There
Oh,
are a few, and they are territorial. They occupy specific region.
territorial. Okay.
Yeah,
Okay.
and the St. John's, the one that operates that are
Okay.
dominant in our area. They have, I think they have a couple, or maybe they have three medical directors around the country that they
Mm.
can access through the phone. They call them for advice.
Okay.
Um,
As I think Nasrina can remember also, our pre-hospital care is partly we attach with an umbilical cord to the hospitals that they are with, and it's a hospital-based service where this is for the public, for the emergency care, and obviously then it's going to be part and parcel of the emergency department as well, and it's managed by the hospital staff, which is the paramedic. Is individual, depends on the individual hospital. For our hospital, for example, in the National University Hospital, we also separated, but the whole country is linked up with one emergency number call, which we have been sort of like plugged into and cover certain area of Kuala Lumpur, uh, 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 some of the district for the emergency response. So we do have St. John's, but they are not in the primary service care. They are in a more supportive care, and they do have services run for emergency as well. And some of them are trained for the emergency service. So, but then they are not the primary really service for the whole pre-hospital care service. Yeah, so that's interesting to note. I know it's quite similar to Australia as well. I think the St. John Metropolitan is doing great job in Melbourne, as I know I have a friend there. Um, and I think they run the same system. It's not hospital based, it's outside of the hospital, and they run their own so-called um, uh, um, uh, management and everything on their own. But they do have doctors also sometimes, emergency physicians having on that, as you said, like the medical director and so on. But they're not the main, they are run by paramedics, advanced paramedics, basically. Yeah, that's quite interesting. All
Yeah,
right,
it's
so
mostly
yeah,
similar here.
yeah.
The ambulance system it's an entity in its own, and they have basic paramedics, advanced, and ICU
Yeah.
level, and those who can provide ICU level of care. Because of the increased demand for ambulance services, they recently, or in the last few years, they introduced extended care paramedics,
Mm.
where those who can provide care in the community and leave the
Right.
patient at the point of care or at home. Like if there's blocked catheter, or there's simple infection, or there's a simple injury, they can fix on site.
Mm. Okay. So they do home visits as well, I assume, right?
Yes, they do. Yeah.
Right. Okay. So maybe some other participants here, you can see quite a few has joined. If you have any questions, please put up your hand and feel free to ask. If you have any queries or anything you want to say, please put up your hand and ask Nurizam and our friends from New Zealand, Dr. Amir and Dr. Nina. So anyway, Nina, you have anything to comment or condemn? It's so surprise.
Sorry.
Not to sound political here, but it's okay. You feel free, free speech here. Say what you want.
It's thank you for the honor of inviting me to join this. And it's really a great opportunity to have somebody from Malaysia to come over and have a look on how different the system is from Malaysia. Honestly, I think Amar noted that I was having a difficult time, very, very difficult time, particularly for the first 2 months because I was really struggling with the system. But in Malaysia, we had paramedics to help us with all the close manner reduction. What else? Simple toilet and suturing. But over here, you have to do it on your own because we don't have the paramedics and they are stationed basically out of hospital. I think that's it's quite minor, but we don't do that in the emergency itself. I think probably because of the patient load, I guess, and we have more doctors, to be honest, back in Malaysia. Like for example, removal of foreign body in the eye. We refer easily to the ophthal team. So
Yes.
it is here that I first learned on, okay, you can do that under slit lamp. I didn't know about it. And yeah, some of the blocks are being used quite a lot here for you to basically proceed with all the minor stuff like refashioning of the injuries of the digits, probably some dislocations as well. And I just want to add on regarding the ambulance system. I think Izam was not fortunate enough to see our air transfer. So we do
Oh,
have, yeah, we do
yeah.
provide. Yeah, I've seen few times severe trauma patients, patients that being intubated, that needed tertiary care, for example, like neurosurgery, being flight over. So they have flight team coming all the way from Wellington Hospital. The one that we have in Sabah is not really a flight care,
No.
flight team,
Mm.
not really. They are all for elective cases. This is true
Mm.
emergency. Sometimes they are being flown over directly to Wellington if the
Mm.
case is really, really bad. So
Mm.
I think that is something which is pretty impressive um, to have that in the place that you're working at. I think they do have almost similar services, but only for our Aborigines, for the Orang Asli people.
Mm.
But the cases in terms of the number is not high, and the funding comes directly under I think it's under the Department of Orang Asli Malaysia. So
Okay.
yeah, so I do have friends
They had
actually
to go
who
in.
has been flying over. Yeah, yeah, but it's not something which is being done for everyone. It's only very limited because we understand it's pretty
So,
expensive.
so the helicopter service, the medevac, is for hospital transfer, or is it for, from site to the hospital, or is it deployed from Palmerston or from somewhere else?
I think they come from Wellington, right, Amar?
Ah,
The one that I've only seen is mainly from Wellington so far because that's the nearest hospital that we will consult
okay.
to. That's our
Okay.
tertiary hospital.
Oh, okay.
So we have access to two types of air transfer. One is just transfer, and we
Mm.
have helicopter on site uh,
Right.
for transfer. So if you have someone with STEMI or someone with stroke and
Mm.
needs to go for clot retrieval or someone who's stable, then we can send them by ambulance from here, by helicopter. But there is a retrieval team. If it's a retrieval, someone
Mm.
that could deteriorate or need a ICU level of care, then the Wellington team will send their ICU crew in a fixed wing or a helicopter.
Okay. So, I mean, we do have something similar, but the services are mainly from either the army that do this transfer, that do the service, or from the other services, ambulance in Sabah, for example, in Sarawak. But we do have retrieval from site where there is, for example, an accident or something, and they go with the what we call fire and rescue. They have a helicopter as well, which go and collect patient, let's say, for example, from the jungle and brought to the hospital. So, for example, we had cases of snake bite in the middle of the jungle and unable to retrieve out with the road. So they will send a helicopter and winch out the patient and brought to the hospital. So that is possible in Malaysia, but it's still not widespread, and not many people have access to that services. It's not really made known per se, as integrated into the healthcare service. So I think maybe in the future, if we have enough money, we will actually have that kind of service. But that's interesting because I know the geography in New Zealand is a bit more challenging, I assume, for quite remote and so on. So that's where medevac, air medevac, would be, I think, more uh, more important to put your money in terms of investment for health instead of building roads everywhere. That is probably not so good for environment as well. So anyway, any other issues that Nurizam that you probably see when you are there in terms of the patient cohort, type of patient, or cases that could be different from our setting?
Yeah, I was told by Dr. Nina they don't have snake bites in New Zealand.
Okay, there's no snakes in New Zealand. No. But you do have tarantulas, so you might go for that one. Yeah.
So yeah, they don't get, like our tropical disease like
And
dengue.
that's tropical, right?
Yeah.
New Zealand is
I
out
mean,
of tropics.
snake bites and animal bites are not there.
Yeah.
So yeah. Other than
So
that,
what kind of cohort of patients is there? Like you said there's mainly geriatric. So
yeah, yes,
from where my
geriatric
experience
because
is, you have falls and fracture of the hip, all these geriatric related injuries. Not so much maybe motor vehicle accident as we see in KL. uh, um, but maybe not so much also related to substance abuse. How is that in or poisoning in Palmerston?
I think I've seen one alcohol
Oh,
withdrawal
very.
is,
Oh, okay.
yeah, but
I would expect more because I was in Ireland, so they drink a lot in Ireland. So every Thursday night and Friday night, we have to brace ourselves for alcohol-related injuries and issues. But is that the same kind of there? No,
I think no, not
no. Yeah. Okay, all right.
maybe. Yeah, maybe
Nah,
the
nah, nah. We
yeah.
do have a lot.
You have okay. Maybe you just did not see it.
Or maybe
Yeah.
Amar want to say something about it.
Go for it. Go for it.
Well, actually, New Zealand, you see quite a lot of patients that misuse
Yeah.
cannabis, and
Yeah.
methamphetamine is a huge thing. They do come in with polypharmacy overdose as well,
Mm,
particularly atypical antipsychotic, SSRI, SSNI. What else? I think yeah. So they do abuse quite a lot actually. But
yeah.
you don't see the stuff that you get to see in Malaysia, such as paraquat. You
Yeah.
don't
Okay.
see
That's
organophosphates.
banned supposedly. Okay.
Yeah. So I
Mm.
think those, but methamphetamine apparently is a huge thing. You do see a lot of patients coming in with cannabis hyperemesis syndrome, which
Okay.
is I've never seen such patient in Malaysia.
Mm.
Alcohol, yes, they do come into yeah. So quite a lot of patient coming in with mental health problem, but because they
Mm.
have such a very strong structure between the mental health team at the hospital with the community, so these patients somehow I'm amazed with how they manage to do the follow up and strengthen the care for this type of patients. The community particularly, they are very well structured. Yeah.
Yeah. Yeah. Yeah. I mean, that's where certain things will actually help to develop when you have the need for it, right? So maybe that is something that not so much developed in Malaysia because we don't see much of those issues. So we don't kind of develop in that sense. Similar to snake bite, I assume, right? So New Zealand has nothing with snakes, so why you want to learn about snake bite? Yeah. Okay. So yeah, that's very insightful, and I assume Nurizam has fulfilled his obligation and also fully his assessment. You guys have assessed him, have you?
No, that
No, didn't. Just go for dinner. That's the main assessment, is it? Okay. Okay, so anyway, do we have any questions from the floor? Anybody would like to ask Nurizam or Dr. Nina and Dr. Amir any questions? Which the best time to visit New Zealand, maybe? Which month? Not the cold winter time. Yeah. No questions. Okay, so Nurizam, maybe you want to maybe we invite Dr. Amir as a summary. If you have any last words to say before we finish.
Yeah, well, look, we enjoyed having Nurizam with us. We look forward to continue to have this collaboration ongoing, and I hope to see more of Nurizam coming here and sharing their experience and taking some good stuff back home.
Meaning more Nurizam working there in the future?
Yeah, and and this is the secondary gains.
Yeah. We do
quickly
exchange program. We can do
provide us with
exchange
the.
program. Yeah. So apa ni, specialist to specialist. Yeah, maybe something to think about. I think there's somebody asking in the chat box. Azhari, how do you pronounce this? What is policy acute admission and allocation of clinical line from Tiwa to Ora?
I think this is the website where referral to the primary team being black and white guideline. But the question was, how do you pronounce? Is it how to pronounce the New Zealand
I don't know.
native?
Maybe Tiwa to Ora T or TP TPI?
I think for Maori word, I'm not so good with my Maori. Sorry, Amar, if I screw this up. But the interesting part is anything that comes in with WH, they don't pronounce it as fa, as they pronounce it as fa. So it's tifatu ora.
Tifatu.
Yes.
Tifatu.
Yeah, so I'm not sure whether I'm saying this one right or not.
Okay,
But I'll
anyway.
try tifatu ora, te pai haurora o Ruahine o Tararua, I guess.
Yes.
Yeah, sounds a bit Hawaiian as well. Yeah,
Maybe.
kind of
Well, they're Polynesian anyway.
Polynesian. Yes.
Yeah,
There's so many
yeah.
words as well, actually.
Yeah, so if you see some words like wangare, you don't say it wangare, ifangare.
Hungary.
Wakapapa is pronounced as fakapapa.
Okay.
Fakatane, wakatane, you see WH and stuff, but it's a fakatane. So that's the part of how the Maori word is being pronounced. So Maori is a huge thing here. Yeah, so yep.
Yeah, okay, that's another question. What's the biggest difficulties for a medical officer working in ED in New Zealand? Besides the weather, I assume.
I see no complaints. If you work in Malaysia and you work in New Zealand, you shouldn't complain.
Yeah, I mean, you have just now you mentioned, you showed there's doctors from Malaysia, housemanship, and
they are housemen, house officers,
okay.
and they work 4 times a week, sometimes 5 times a week. They work in shift, 10-hour shift, and what else? I think formally.
But how did they get to go into the housemanship program in New Zealand? Were they studying there?
Like Shazwan, he was a medical officer in Malaysia for a year.
Okay.
He finished housemanship in Malaysia, then he became a medical officer for a year before he go to Palmerston North. But he joined as a house officer in
Oh, I think, are you asking about the pathway then? Is it the pathway?
No, it says here what's the difficulties.
So for
is the pathway very difficult?
So from my observation, most of the difficulties come from cultural differences between practicing medicine in Malaysia and New Zealand, and this can have an impact on the well-being of the house officer and even the relationship with patients. Patients here are empowered to challenge doctors and and be directly involved within some decision making. And sometimes even when the decision making is not very clear, we ask the patient about, we give them options and we tell them it's a gray area and we need to make a shared decision together, whether we should wait or should do more investigations at this stage. And patients feel dismissed and they tend to complain when the doctors, they just make decision on their behalf
Yeah.
without
Yeah.
giving them room to discuss. The other the other cultural differences is which we've noticed that, and some of the Malaysian doctors reported, is that when there is a pediatric resuscitation, usually the family wait outside, while the culture in New Zealand is to
Have the family.
actively give the family opportunity to be present during the pediatric resuscitation.
Okay. Yeah, that's interesting. No language barrier, I assume, with patients.
Yeah, mostly they get by. We've seen some cultural, some language challenges, but most of the time, it's not a big issue. Mostly it mostly the issues related, the challenges related to the culture of patient-doctor relationship, and also the
Yes.
culture of being working under supervision. There's much more intense supervision here, and the RMOs get, they come and present, and the way that the house officer progress is more controlled than Malaysia. So if you are at a certain level in your career, you cannot do this without being accredited to do it. For example, you cannot, if you are PGY 2 or 3, you cannot say, I'm going to intubate someone without
Yeah.
being, trusted to do that. Under wind courses, you are in training, you have a consultant around to supervise you. And so so it has its own pros and cons, but the scope can be limited as well, until people know you, they become familiar with your abilities, and you are progressing in the system, and that
Yeah.
takes some time.
Yeah. Well, there's always pro and cons, but some freehand is sometimes is needed also for you to practice. But I think the supervision is very important, I think. And I think in Malaysia, I can only speak from my hospital. We do have this logbook system as well, and also opportunity with what we call practice on dummies and simulations and so on. So that adds on to this issue of directly in contact with patients for practice. So anyway, and from the medical student side, from the medical side, that is also part of the medical education system that we have, where students are more into simulation type or scenario type experiences rather than directly onto patients, which can be quite difficult sometimes. Yeah. Yeah. Okay. So thank you for that. I think, do we have any more questions? I can't see any more questions there. So thank you, Dr. Amir. Nina, would you like to say something? Last words? Not last words, maybe some some guidance,
Sunset.
perhaps. Yeah. Summary.
I just wanted to add on about the culture differences. Over here, they do allow transgender marriage.
Oh, okay.
Yeah. So sometimes probably you can see like they identify themselves as husband and wife, but they're in the same gender, or probably one person could be transgender. So that is something that you don't see in Malaysia at all, and you gotta have to respect that.
Yeah.
Yeah, so you have to address them accordingly. Yep. Yeah. So I think nothing much, but I have to say that I think the work-life balance here is amazing.
Oh,
I have to be
yeah.
honest with that. And I really love the way on how things are being done and planned. Like you have, you are being allocated certain amount to basically do your medical education, your CMEs. You can go for
Right.
conferences, you get funded for that. And there is for the consultants, you work for 3 clinical shifts, 1 non-clinical shift where you can do teaching, you can do your research, and teach other people if it is on your education day. So I think that is something which is really, really helpful, because in Malaysia, you just have to squeeze in between to do all those things. It's,
Yes.
I mean, particularly if you're working in the public hospital, the system where I was from. So
Yes.
it's really
So
nice.
Palmerston is affiliated to a university, or is it a training hospital, or fully private public hospital?
It is a public hospital, but I think Amar is one of the supervisor for the trainees, the students from Otago Medical University, right, Amar?
Okay.
Yeah. So yeah,
Yeah.
yeah. So so the hospital is a training site, and we mostly see medical students from Otago University, and the undergrad is conducted by the university, and the postgrad is conducted by the college, which is an Australasian college. It
Okay.
has, it's not a university. It's a bit probably different from Malaysia. So so medical students come to us for their for their 6th year,
Final.
and for their PGY 1 and 2. And then the trainees who want, we are accredited to for a few specialties in the hospital to conduct training, postgraduate training, like anesthesia, medicine, ED, pediatric. And we are, our ED is accredited by the college to have trainees for up to 2 years.
Yeah, because I saw Nurizam's picture. There's one at the back when she was wearing the scrub. There's a student label at the back. Of
Yes,
the
good
scrub.
observation. Yeah, good observation.
Okay.
Yeah,
So that's postgraduate or undergraduate?
yeah, usually undergraduate.
Undergraduate. Okay.
Yeah.
All right. So yeah, thank you so much. Okay. So back to Nurizam. I pass to you. You have anything
I think
final things to say? Or
in
say goodbye?
summary, I would advise my colleagues or my friend, if you have opportunity and you have the fund or capital, I mean money, do go overseas, other countries, to just open your eyes. It's an eye-opener experience, how things work differently, because all your life you've been staying in, like myself, I was in KKM for quite some time before I joined the master program. So I would say go out and see how things are being done differently in other hospital, how the culture, the working culture is important, the respect, working culture, and yeah, like Dr. Nina highlights, the work-life balance is important, because yeah, and I was aware that there's a very good union support, non-judgmental, and they get free coffee, free meals for doctors.
Yeah.
Yeah, it's at level 1. I would go and get a free coffee. So yeah.
Okay.
So yeah, I think it was a great experience for me myself. Uh, that's all I think. Yeah.
Okay, so we'd like to say thank you to everybody. Good job, Nurizam, and thank you, Tamer and Nasrina. Whenever you're in KL, feel free to drop by. We'll definitely have coffee, surely. Okay, so till next time, I bid you thank you. So Nurizam,
Thanks. Yeah, thanks a lot, Dr. Amir and Dr. Nina, for having me in Palmerston.
It's a pleasure.
Appreciate it a lot.
It's a pleasure.
You're welcome.
Okay.
okay,
Thank you,
bye.
everyone.
Okay.
Assalamualaikum. Bye.
Salam.
Salam.